About the size of your fist, the human heart is the most important muscle in the body. The right atrium, right ventricle, left atrium, and left ventricle. The right side of the heart receives blood that is low in oxygen from veins all over the body. It then pumps the blood through the pulmonary arteries into the lungs where it will become reoxygenated. The left side of the heart receives this oxygen-rich blood from the lungs. Then it pumps the blood through the aorta back out to the rest of the body through a complex network of arteries, arterioles, and capillaries. While blood is circulating through the body, it delivers oxygen and nutrients to tissue through the capillaries, and at the same time picks up carbon dioxide and other waste material. The veins return the deoxygenated blood to the right atrium, and the cycle begins again. The heart has 4 valves. Each valve is like a one-way door that keeps the blood in the heart flowing in the same direction. The valves are made up of 2 or 3 small but strong flaps of tissue called leaflets. Leaflets open to allow blood to flow through the valve and close to prevent blood from flowing backward. The opening and closing of the valves is controlled by blood pressure changes within each heart chamber. The tricuspid valve is positioned in the heart's right side, between the right atrium and right ventricle. The pulmonic valve separates the right ventricle from the pulmonary artery. The mitral valve is positioned in the heart's left side, between the left atrium and the left ventricle. And the aortic valve separates the left ventricle from the aorta. As blood circulates through the heart, some of the blood surround or crown the heart. This separate circulatory system, called coronary circulation, keeps the heart nourished and oxygenated. The 2 main branches of the aorta that nourish the heart are the right and left main coronary arteries. Coronary artery disease, which occurs when there is a buildup of cholesterol plaque, affects the arteries of this circulatory system and causes a decrease in blood flow to the heart muscle, resulting in possible damage to the heart or a heart attack. The beating of the heart, which is its rhythm, is regulated by electrical impulses generated by your heart muscle, cause your heart to contract. Sometimes the sinoatrial node is also referred to as your heart's natural pacemaker, since it keeps the heart rate constant and consistent. The impulses then travel to the atrioventricular node, where the signal is checked and then sent through the ventricles, which causes them to contract. Your heart rate can change based upon external conditions such as diet, exercise, stress, or even hormonal factors.
This animation will highlight select aspects of robotic radical prostatectomy and presents a simplified view of the anatomy of this area of the body. We begin with a view of the endopelvic fascia. Beneath the endopelvic fascia, we see the bladder and prostate, along with other structural elements. In this view, we also see the levator fascia, which covers the prostate. The pelvic plexus is found on the anterolateral aspect of the rectum. The important erectile components of this plexus include the vesical plexus and the prostatic plexus, and interconnecting nerve fibers. These ganglions and neuronal connections form a proximal neurovascular plate, which can be injured during dissection of the seminal vesicles. The neurovascular plate coalesces to form the neurovascular bundle, the complex of nerves and blood vessels on the posterolateral aspect of the prostate. The neurovascular bundles lie on each side of the prostate, between the prostatic fascia and the levator fascia. On the bottom, they're bounded by Dunouvillier's fascia. The space in which the bundles are located is the neurovascular triangle. Moving to the apex of the prostate, we can see the pubic bones and puboprostatic ligaments, the dorsal venous complex, and the striated urethral sphincter. Our animation of the surgery begins with the separation of the bladder and prostate. Once the bladder neck is clearly identified, the 2 organs are carefully cut apart. Next, the retrotrigonal fibromuscular layer is identified and cut through to expose the anterior surfaces of the vas deferentia and seminal vesicles. From this point forward, the surgery is done without cautery. The vas deferentia and the arteries running to them are secured athermally and cut. The vas deferentia and seminal vesicles are then lifted up and secured to the prostate base with a stitch. The prostate is now lifted up and de Novillier's fascia is separated. The blood vessels in the foreground in this section are secured athermally using minute clips or sutures and cut. Here we illustrate how the robotic instruments, which are able to move in almost any direction, accomplish this. Next, the prostate is retracted to one side and an incision is made in the levator fascia over the neurovascular bundle, exposing the neurovascular triangle. This provides an initial release of the neurovascular bundles. The neurovascular triangle is entered and the bundles are released by cutting close to the prostatic fascia, as blood vessels in this section are secured and cut. Once completely released, the bundles fall away from the apex. This procedure is repeated for the neurovascular bundles on both sides. Another key step in the surgery is the development of the apical notch and transection of the urethra. At this point in the surgery, the prostate is attached only at the apex. The prostate is pulled back so that the puboprostatic ligaments are exposed and can be cut close to the prostate. The dorsovenous complex is now also secured and then cut. Next, the prostate is freed from the striated urethral sphincter, and the urethra is cut. The Foley catheter can be seen here. This frees the prostate for removal from the body. In this surgical technique, the nerves and blood vessels that are key to maintaining sexual functioning should still be preserved at the end of the operation. The bladder neck and the urethra are now carefully sutured together so that the nerves are not trapped in the suturing and the operation can be completed.
When we try cases, we use all type of technology. We use exhibits that we can show the body part that has been affected or broken. We have anatomical models from feet to knees, to backs, to discs, to necks. We have electronic models that we use if need be. We have animations that we can make available if you've been in a tractor-trailer case, or if you've had bad medical care where a surgery has gone wrong. We can have anatomical models that show where that error occurred. We have all types of anatomical models and animations that can be used to get our message and your message across to the jury.
Close inspection of an area of the outer surface of the brain and inner surface of the skull during the initial impact shows the soft, fragile brain scraping against the hard, jagged inner surfaces of the skull to create shearing forces. As the gray matter, comprised of cell bodies, and the white matter, comprised of axons, are of two different densities, the shearing forces create a plane of cleavage where many axonal injuries occur. The axons may be completely torn, partially torn, or separated from their connections with other cells. Thousands or even millions of scattered axons may be torn. But unless some of the larger and more resilient arteries are also torn, no bleeding occurs. Traditional imaging studies such as CT or MRI are not nearly sensitive enough to detect individual axonal injuries, or even relatively large groups of axonal injuries. CT and MRI are designed to detect areas of bleeding. Unless a blood vessel or multiple vessels are torn, creating a relatively large bleed, these studies fail to demonstrate any findings that would indicate the presence of multiple, widespread, and microscopic axonal injuries that can result in devastating neuropsychological deficits. in situations when the forces involved are severe enough to result in injury to the blood vessels. The injuries to the axons are even more severe. An injury to one or more blood vessels results in the release of red blood cells into the surrounding brain tissue. CT and MRI are designed to detect blood, or after a period of time, the remnants of blood called hemosiderin. Large quantities of red blood cells must hemorrhage from a blood vessel or blood vessels to be detectable on CT or MRI. If even one small hemorrhage occurs that is detectable, it is an indicator that there are likely vast numbers of associated axonal injuries that are not depicted in the scans. In addition to the deceleration forces, rotational forces are typically involved in most collisions. The combination of rotational and deceleration forces results in traumatic forces on the brain that may be far greater than the force of the collision may imply. This combination of forces is very similar to combining cold temperatures with high winds. Either alone may be tolerable, but when temperatures of 30 degrees are combined with winds of 30 miles per hour, the net effect can be quite chilling. When the skull and brain are viewed in section from above, it can be seen that the brain consists of two halves that are connected by only a few central structures. One of these structures is called the corpus callosum. The corpus callosum consists of axons that allow for communication between the opposite sides of the brain. The front of the corpus callosum is called the genu. The two halves of the brain are separated by a tough, ligamentous structure called the falx. The falx is rigidly fixed to the skull in the front, back, top, and bottom of the skull. During the violence of an impact involving the combined sudden deceleration and rotational forces, similar to the one shown in earlier animation sequences, the corpus callosum can often become injured. The injuries occur because the soft, friable brain reacts in a very fluid-like way as a result of the violent forces. The left side of the brain impacts against the falx, and the right side of the brain pulls away from the falx. Because the falx is rigid,